and welcome to this latest Levelling Up Goals seminar. I'm Ian Dale. I'm going to be chairing the seminar over the next 3/4 of an hour, depending on how we go. Now, today, we're going to be looking at Levelling Up Goal number 8. And that is called Good Health and Wellbeing, improving mental and physical health at all ages to boost overall wellbeing to allow people to fulfill their potential. And we're delighted to have the support of Primary Health Properties, PHP, for this webinar. Let me introduce the panel to you. We have with us Justine Greening, former Education Secretary, International Development Secretary and Transport Secretary. And of course, Justine is the founder and chair of the Purpose Coalition and Levelling Up Goals. Also, Harry Hyman is founder of Primary Health Properties, and he's now chief executive of the company as well. And also joining us is Patricia Davis. She's the chief executive of Shropshire Community Health NHS Trust. She was appointed in April 2021, and we look forward to a really good discussion over all of the issues. And let's face it, at the moment, given we're post-COVID, there are a hell of a lot of issues to discuss. Now, Justine, let's start with you. Do you want to just introduce this particular levelling up goal, and then we'll go on to discuss some of the issues around it?
I will. Thanks very much, Ian. And it's great to have both Harry and Patricia on the webinar as well. Goal 8, as Ian said, is around good health and well-being. And it's absolutely at the heart of how we will deliver a levelled up Britain. And in fact, back in 2010, there was actually a seminal report by Professor Michael Marmot that I'm sure Patricia's exceptionally familiar with. And he really laid out in very clear-cut detail this link between healthy lives and a fairer society. And Michael talked about a social gradient that actually often the more disadvantaged people were, the less healthier they were, and that inextricably was linked to their financial prospects as well. Since then, of course, a lot more work has been done that really has understood that relationship ever more clearly. And of course, when we got to COVID, we really saw very starkly this relationship between health inequalities and levelling up. And there was some work done that showed that for people who were under 65 in the poorest 10% of areas of England, they were nearly 4 times more likely to die of COVID than people who are more privileged and living in the wealthiest areas. And we, of course, saw the wider issues around disadvantage playing out with COVID, whether you were disabled and more at risk. Of course, in other communities like ethnic minority communities, a higher prevalence of challenge when it came to the impact of COVID on people. So all of these things woven together that really underline the link between health inequalities and levelling up. And of course, when you talk to council leaders, many of them will point to the fact that in a single community almost that they serve as the local authority, there'll be one ward that has one level of life expectancy right next door to another ward, more disadvantaged, with a lower level of life expectancy. So these things go hand in hand. I think the final point I really want to make is that when you look at health inequalities and the health agenda, and I think it would be really interesting to hear from Patricia on this, you start to see some of the wider ways in which we fix levelling up, because they are around getting upstream and prevention. They're around wider public health. And so I think in understanding how we can reduce health inequalities, actually a lot of those measures and interventions we might take very much then show the way forward, if you like, on the wider levelling up agenda more broadly. So a really good discussion ahead, and fantastic to have Harry Hyman, who founded PHP. It really does work alongside, I mean, thousands, probably hundreds of thousands, he'll tell us, of GPs across the country in enabling them to be able to provide a primary healthcare service, if you like, that is the best that it possibly can be. So yes, over to you, Ian, and looking forward to a really good discussion.
Thanks, Justine. Well, let's move on to Harry. Harry, do you just want to introduce your company to us and tell us exactly what it does and what your motivations are for being involved in this webinar?
Yeah, sure. Thank you very much. So Primary Health Properties is a company that's been going as a public company for 25 years. And we have a very simple mission, which is to invest in the social infrastructure of primary care properties across the whole of the UK and also now in the Republic of Ireland. We have some £2.7 billion worth of investment in around 520 medical centres, of which 500 are in the UK, and we cover something like 7% of the British population that are registered at medical centres that we own. We're not involved in the service delivery of the healthcare, which remains free at the point of delivery, but having the right sort of infrastructure can make one heck of a difference to the ability of doctors' practices to accommodate all the additional services that are now part and parcel of primary care. When I first remember going to see the doctor, I sat in the guy's front room of what was basically his house and had that sugar cube with the polio vaccine on it. People as old as me might be able to remember that.
I'm going to say you're showing your age, Harry.
Yeah, absolutely. But it was a single doctor in a large house. And in today's society, largely gone are the single-handed practices. And what we need now is a much larger number of multidisciplinary practices offering a wider range of services, which can include social prescribing, which comes back to Justine's point about the prevention agenda. So instead of viewing going to the medical centre as only going there when you're not well, perhaps it's better to think of it as a wellness centre where people can be educated in the plus points out of being out of having a good physical existence, musculoskeletal, physiotherapy, diet, drug and alcohol abuse, and keeping on that healthy agenda, which not only will make the citizens' lives healthier and better and longer, but will also reduce the financial pressure on our hard-stretched NHS. And just to come back to one further point, which is that primary care is a little bit understood. It's your first port of call in your patient journey, and keeping people out of hospital is a very important agenda item, but having the right infrastructure and having the ability to tap into these sources of capital is incredibly important, because as opposed to those days when the doctor was expected to provide his accommodation, which was largely residential, now these are freestanding, very large medical centres which can accommodate this much wider range of services that I've been talking about. So PHP is delighted to play its part in doing that. And we really get, this is part of our social purpose in investing in the healthcare infrastructure of our country.
And how do the medical centres that you own and manage, how are they different to maybe some of the others, which is basically an opportunity for you to say how brilliant you are?
Well, I suspect that they are much larger. The average lot size of the properties across our portfolio is something like £5 million, and the sort of modal number of doctors is anywhere between 6 and 10. But very important is this much wider range of services, including access to pharmacy, which is very often co-located with a medical centre. And we've seen a lot of discussion in the papers and social media about the digital disruption, which fortunately was there so that we could carry on seeing the GP over Zoom during the COVID pandemic. But that's not a panacea, a universal cure for everything. People still need to go to see their medical practitioners and the wider level of staff, because you need to take a more holistic view of the patient than you can do over Zoom. And we mustn't forget that quite a significant minority of the population don't have access to the internet, don't have access to an iPhone, and would find it difficult sometimes because of their mental problems or dementia, to actually access online solutions without the help of a carer. So it's very, very important to remember this, and this holistic total patient picture can only really be delivered out of the bigger, better medical centres that we're so interested in providing.
Patricia, you are Chief Executive of Shropshire Community Health NHS Trust. Just to explain, I'm sure most people who are watching this probably know what a community NHS trust is, but just explain what you do.
Yes, certainly. And so we provide community-based services. So when we talk about primary care, people tend to think about general practice, but actually community services are part of that wider brief in terms of primary care. So we deliver traditionally district nursing, community nursing services, physiotherapy, dentistry, everything which is out of hospital. Although we also run hospitals, we run community hospitals. I've got 5 of them across a very rural area, in some quite in buildings which predate the NHS. So listening to sort of Harry's view around up-to-date facilities is really important from our perspective too. So we provide everything which is out of hospital, and our key focus is not only delivering care and treatment in people's homes and other buildings within the community, but also providing that prevention. And the point that Justin made, COVID has really sort of illuminated within our services those who need more input. So I think from a community perspective, we provide everything which is outside of an acute trust in terms of care within people's homes, but also within buildings as well. And that building and estate element is becoming even more crucial, as Harry pointed out, in terms of being able to deliver effective, up-to-date, modern 21st century style healthcare facilities that brings people together. Not just community services with primary care and wrapping services around primary care, but also bringing into play local authorities and indeed communities themselves to play an active role in that well-being element, and also bringing in not only social prescribing, but that whole issue of the economic regeneration, sort of starting to bring into play employment, training and development opportunities for communities as well. So that kind of how you create health and well-being hubs within communities is something which is very important in terms of my service strategically, but also the health service in general.
And the challenges that you face in a predominantly rural area like Shropshire, how do they differ from your colleagues maybe in other parts of the country?
For sure. So I cover Shropshire, Telford and Wrekin, and we've got Telford and Wrekin, which has areas of high urban, high levels of deprivation. So the point that Justine pointed out, there are 18 wards within Telford and Wrekin, 10 of which are within the most deprived areas in England and Wales, next to 8 of which are in the most affluent. And then you've got Shropshire County, 65% of which is rural. And so there's a challenge there, not just in terms of delivering buildings, but also the flexibility, being able to connect parts of rural Shropshire that predominantly have an older ageing population, but we also have some of our most deprived younger populations as well that feeling isolated from the rest of the economy. And when you start to think about then younger people staying in Shropshire to take up jobs, particularly in agriculture and other areas where we're seeing gaps, we need to be harnessing that in a different way. So that connectivity, the challenge of connectivity across a rural community is a challenge for us.
And if we look at this good health and well-being levelling up goal, do you think that we have to divide our discussion into a sort of pre-COVID and post, or during COVID and post-COVID discussion? Because I imagine if we'd been having this discussion in late 2019, it would be framed very differently to the one that maybe we're about to have, and the challenges that COVID has provided in all sorts of healthcare. And Harry, I imagine even in the provision of buildings, that there have been implications because of COVID. Maybe you could touch on that a little bit.
Yeah, well, throughout it all, we've been very keen to reach out to our tenants and the NHS to make sure that our buildings can be adapted quickly and flexibly to the changing needs that we had during the pandemic. And of course, we mustn't forget the important role that primary care will have moving forward on things like the booster jabs. I mean, the NHS has done an absolutely fantastic job in getting us to the levels of immunisation we've currently got. But as we know, there's children still to go, and there's also the boosters. And you're right. I mean, the pandemic has shone a spotlight on the need for robust and resilient primary care, and some senior people in NHS England have realised, or said to me, that they've realised how overly dependent they were historically on the hospital system, And really, the thing you don't want to do now is send people to hospital. You want to keep that for very acute and traumatic situations, and keep the patient base away from what might be hotspots dealing with unfortunate COVID patients. So primary care has got an amazingly important role to play. But I think the other lesson that is learnt is that you cannot just move away and move on to a Zoom consultation solution. And we've seen in the recent past some highlighting of that by the BMA and the Royal College of GPs, showing how important it is for patients to come back and see their medical practitioner face to face.
Well, that's quite a controversial thing, isn't it? Because certainly quite a few GPs I talk to are eulogizing about the fact that they can do more things remotely. It means that they have more time, they can be equally efficient. I mean, Patricia, you're at the sharp end of this. What lobbying are you getting on that?
I think there's some and some, isn't there? So I think there is an element where pre-COVID, digital technology within primary care, and my previous role before joining Shropshire Healthcare was within commissioning and primary care, and 80% of consultations pre-COVID were done face-to-face, and it's flipped the other way. Now 80% are done digitally. And I think certainly the Royal College of General Practitioners were kind of saying that we needed to get to a balance of around 40 to 50% digital technology and face-to-face. So I think there's the element certainly where, yes, GPs are eulogising that, my word, this technology that we can use that can not only improve our work-life balance, but actually provide a real effective tool of treating patients and keeping them well, most importantly. And I think we need to do more around the digital agenda. We've progressed within 2 years more than we've done digitally in primary care and other parts of healthcare within the last 20 years. So I think that's been a real positive element of COVID. But then there's there are times where, as a clinician myself, you've got to be able to physically touch and examine the patient. Yeah. And there are other elements around that whole face-to-face counselling and support mechanism for patients that where you need to have that face-to-face contact. So there is that element of having to think slightly differently about buildings and how you bring people together. As I said before, it's not just about that contact with the GP in terms of a diagnosis or getting access to treatment, but it's the wider issues that are creating the issue for the patient. And just going back to your question around, do we need to think differently? I think in terms of inequalities, COVID has just exacerbated the inequalities that existed within certain communities. And I think how we deal with the backlog, as well as think strategically in the long term around how we then close that gap, I think is quite important. And how we think differently in terms of, I think part of the solution isn't just about the delivery of healthcare, but it's how healthcare can be an important part of supporting local councils and communities in that economic regeneration of high streets and so on, that brings people together in a very different way. So I think COVID has just exacerbated many of the inequalities that existed previously.
And Justine, the digital divide, I suppose, here, it feeds into that levelling out goal, doesn't it, too? Because, I mean, I had never heard of Zoom until COVID, and yet here we are, we're all talking remotely. We wouldn't have been able to do this. You'd have probably been asking Harry and Patricia to come down to London to record this in person, which obviously we'd have all preferred, but hey. But when you look at the remote appointments, that's actually emblematic of the whole divide in the health service in many ways, or healthcare, where those people who have computers, who have laptops, who know how to use Zoom, fine, they can do all of these remote appointments, but I don't know what percentage of the population there are who just wouldn't even be able to think about doing it, because they might not even have a broadband connection, they might not even have a laptop. Now, that would have been the same pre-COVID as it is now, I guess. Or do you think that maybe COVID has enabled people to, certainly with all the laptops that went out to school children from poorer backgrounds, maybe that has helped things?
I think at the end of the day, what COVID has done is turbocharged a trend that was already there around online life, basically, and that includes in relation to healthcare. And I think Patricia's right that actually there's been a lot of progress made by the NHS in an incredibly short period of time to do better online health. And as ever, whenever you have change, there's some opportunities and there's some threats. The opportunities are that probably for a lot of people, perhaps younger people, busier lives, who maybe put off going to see a GP when they really ought to have done, for them, it may well be that this online access to their primary healthcare facilities locally just simply makes it a lot easier, and actually you get much better uptick of services. I think when you talk to some universities and they talk about their student services and particularly student support, actually having to put it online, they ended up reaching a quite different, slightly wider group of students than they otherwise would have done. And many of those students would have been people who were far more reticent about coming forward. So for example, male students on mental health who maybe would have not particularly wanted to sit and wait for the office to open. But on the other hand, the threat is, there's a lot of people, often the most vulnerable, the elderly, who aren't online. And for them, actually being able to get in to see a GP, often a GP that they know and trust, is going to remain incredibly important. And that will be the case for other people, whatever age, who do just need to see someone to talk about whatever it is they're concerned about. And ditto, there's a healthcare provision piece of this. There are some things you just can't do as good a job in terms of diagnosing and advising and treating online. So it is a brave new world in a sense that we are moving into. We're just going to have to deal with those challenges. But let's not lose sight of the fact that in other ways, it can be part of how we do actually manage to get further, faster on levelling up. And I thought Patricia and indeed Harry made a really interesting point on those wider health facilities that you could put right in the centre of communities. They're going to be a chance not just to have people better able to access facilities and this transition of a high street almost into not stopping being a place where you used to go and buy stuff to becoming more a place where it's a social centre, where you go and get things you need, or you see friends, or you go to the library, or you access your healthcare. That shift for the NHS can also be a means by which it brings some amazing careers in an incredible organisation and puts them right on the doorstep of often some of the most deprived communities. So it's almost not just about the healthcare piece of this, it's also about the piece of it that is saying the NHS as an employer has some incredible roles, and it can extend those to a much wider talent pool through doing a better job of actually getting that talent pool better services for their health as well.
And in a way, I think one of the frustrations that people feel, probably in the sectors that affect all of the different levelling up goals, is that maybe there isn't enough leadership here. Harry, when you look at the leadership in the health sector, which you're part of, albeit not providing the healthcare, are you frustrated by the fact that sometimes the political leadership seems absent, or even within the NHS there are so many competing lobbies within the NHS that sometimes the whole levelling up argument, I think, gets obscured by the different vested interests?
Well, that's a very wide-ranging and difficult question to answer, but I think the answer is that we can become frustrated, but I think that's almost inevitable when you're dealing with an organisation as complex and large as the NHS, and we mustn't forget what an all-round fantastic job it's done during the last couple of years, particularly in dealing with this awful pandemic that we've been through. But having said that, yeah, very much. I mean, we like others in our sector have been cajoling and asking for more investment in primary care to come, and that needs changes to be instituted by the NHS at the centre. I think at the very top of the NHS, people understand this, but of course there's been a huge amount of administrative change, and we're going to see another raft of that with the introduction of integrated care systems as are going to be in place from next April. But of course, the benefits of those integrated care systems, I think, outweigh the short-term slight hiatus in change that there's been. And it's not my position really to be overly critical of the NHS. It does a fantastic job, but we do get frustrated. And of course, everybody would like there to be more money, for it to be delivered faster. But of course, we're dealing with public sector funding here, and it has to go through the proper processes and rigorous checks that it goes through. I mean, to put it in context, we're deploying over £100 million worth of new capital every year into the primary care agenda, and that's alongside an NHS that is busy, as we all know, dealing with the day-to-day, the backlog, the pandemic, and booster jabs. So we have to remember all that.
Patricia, people often see large public sector organisations as very slow to react to events. Now, in many ways, the NHS was incredibly quick to react to events in the pandemic. But as somebody who works at the sharp end, what are the frustrations for you? When is it difficult to, if you have an idea? I mean, if I have an idea for my radio show, I have to ask one person before I can implement it. I suspect that's not quite the same in the NHS. Now, is that a matter of frustration where you can see what needs to be improved, particularly in levelling up terms? You know what has to be done, but you have to get authorization from goodness knows how many people at different levels within the organisation, or am I imagining that?
No, you're not imagining it. I mean, there is an element of some liberty within your own organisation and within your own governance structures, but equally, we are part of a national health service, which is subject to standards, targets, and so on, that we're held to account for, and that's just right and proper on one level. But then it can be a bit clunky, as you say, in terms of the balance of what we need to achieve at a national level to what you can achieve locally. And Harry was talking about the funding stream in terms of primary and community services comparative to the acute sector. If you think about, is it 10% of people, acute hospitals are really, really important for treating people, but, they deal with 10% of the population, whereas the rest of us in the community, local authorities and primary care deal with the 90% of people. And when you're talking about keeping well, and yet when you look at that commissioning cake, 2/3 of the funding flows to the acute sector. So we've got to do something about that funding stream. And whilst the pressures at the moment are very acute in terms of the acute trusts, in terms of people non-electively flowing into the acute trusts and A&E departments, which is well recorded, we've got to be bold. We've got to think downstream if we're going to really tackle the levelling up issues. And really tackle sustainability for the health and social care services in the future, then we've got to think about prevention. So it does require leadership and an element of being bold from NHS England and NHS Improvement's perspective in terms of turning that tanker. But I think we need that cross-political and government support to make it happen as well. So there is an element there of both boldness from the higher echelons of NHS leadership alongside, if we are truly going to be local, then the integrated care systems, and I picked up on perhaps Harry's a little bit reticence around ICSs and what they're going to deliver, being part of an ICS. I think there has to be, if we're truly going to make integrated care systems, local authorities and health work together, then there has to be devolution of both funding and decision making at that level. And at the moment, that doesn't exist.
Justine, from a political point of view, you've been a Secretary of State, not in the Department of Health, but I imagine it was probably very similar in education, if not transport, where you're the Secretary of State, you want something done, you press a button expecting levers to be pulled, but sometimes I imagine it can take a very long time for the machine to make to reform and make things different. Is that something that can ever change?
Well, I think in some cases, it just simply requires better decision making. I never did expect the system just to change because I'd issued an edict. And I think the problem is when a Secretary of State says, right, let's just do this, and then assumes that this is all possible. The smart thing to do is genuinely to work through bottomed out plans and to make sure that what you're thinking is a good idea really is, that it, particularly if it's health, I think, doesn't have some counterproductive impacts that you're entirely unaware of. And often when you look at why we don't have a more preventative approach on policy, and social services is a very good example of this. Often Parliament's legislating when something's gone really badly wrong. And so what happens is, for those emergency cases and moments, we then pass a law saying this should never happen. But actually, in doing so, we codify all of the acute challenges people often face in their lives and leave the preventative piece untouched. And so, of course, what happens for public services then in these sorts of areas is they have to focus on the acute piece. And over time, the squeeze on the amount of resources left for prevention becomes ever greater. So nobody means for this to happen, but in practice, that's actually what does happen. And I think
that's particularly true at the moment, I would think.
Absolutely. And it's all understandable, but in a sense, what you need is to have more evidence-based, system-wide look at policy in order to really genuinely say, for the long term, are we taking the smartest approach that we can do that generally ends up also being the most cost-effective approach? Healthier lives cost less for the state, and lives that are productive generate more for people, not just in terms of well-being, but also tax. So lives on track is good, not just for individuals, but also for the exchequer. And I think taking that longer term approach across government is key to unlocking better decisions. And as we've seen, I mean, COVID's been a real challenge for the NHS. It's absolutely forced it to sort of meet this short-term emergency. But what it still desperately needs behind that is this longer term approach. And Sir Simon Stevens really had a good go at that with his 5-year plan. But even then, when you look at that time frame, it probably needed to be, longer still. And I think it's that long term approach that we now need to take. And I think the other piece of it that really comes into what both Patricia and Harry were talking about is that it's not just, if you like, the public sector and government making decisions. Actually, employers, more broadly business, have a massive role to play in shifting the dial on preventative health and being places of work where people are likely to stay healthy rather than perhaps to end up going off sick. And so all of those sorts of issues, I started off by talking about Michael Marmot and his work, Healthy Lives, Fairer Society. Actually, a fairer society where people feel they can succeed in their roles and their careers, and employers who make that happen, is probably, a big part of how we can tilt towards a more leveled up Britain, but also one where people feel more fulfilled and are less likely to be stressed and off work and unhealthy. And so these things all go hand in hand, and we're trying to get away from this vicious circle where you have poor health outcomes, poor employment outcomes, and poor societal outcomes, to one where you have better versions of all of them. And actually, you'll get more money out of your NHS and better value for money at the same time. So it is the ultimate win-win that we're all aiming for here, I think.
And Patricia, I think it's really interesting that Harry's involvement in this webinar, where I think most people don't think about the fact that the healthcare sector is incredibly wide. It's not all about doctors and nurses. It is about buildings as well. It is about the service providers. It is about the manufacturers who manufacture all the equipment that's used in surgeries and hospitals. What role do you think that these wider sort of stakeholders can play in the whole levelling up agenda in healthcare?
A huge role. People don't, as you say, people don't realise that we operate across a number of different sort of industries, and I think there's a lot more that we can do and should do and be open to from an NHS and a public sector background. And sometimes that's seen quite negatively in terms of, well, the NHS is a public service and it needs to remain so. I'm very passionate and believe that. but also we need to work in tandem. If we are going to level up, then we do have to work in tandem with other industries to tackle some of those wider determinants of health. So, you know, I see my role as a community health chief exec being actively involved and supporting our local authorities around economic regeneration of our towns and cities by working with private industry to create better job enhancements. I mentioned that I work in buildings. We operate from buildings which are pre-NHS, very Victorian, actually working with people like Harry and private sector industries can transform the way that we deliver care in terms of the provision of capital and in terms of the provision of wider employment for people as well. So I think there's a greater relationship that's needed, and also the very important element that Harry's industry is far more agile, as you pointed out here, than the NHS and public services. We deal in public money. There has to be governance, and sometimes that is clunky, but actually working with other organisations can allow us to be a little bit more flexible and to take measured risk in a different way. So I think going forward, integrated care systems need to embrace working with a plethora of private sector organisations and local community organisations to deliver for the needs of, you know, population health. We're moving as a health system away from, and I think this is going to be the platform to help with sort of the levelling up agenda, away from delivering care based on activity versus cost. You know, we count how many people are in the population, and then we sort of an educated finger in the wind around how we deliver healthcare for the future, and then something like COVID comes along and we become focused on the here and now. But by taking a population health focus on the way that our populations are going to transform over time, allows us to target money in a very different way. So we start to deliver contracts based on outcomes as opposed to inputs. I think that will make a big change, and it will allow us and force us a little bit more. And it goes back to your point, Ian, around the flexibility of being able to make local decisions and work with a wider variety of organisations to deliver those local population health outcomes. So I think the relationship is going to get stronger and should get stronger.
Harry, whenever I do a health related phone in on my radio show, or if it's to do with policy, it often becomes embroiled in a debate between the public sector good, private sector bad. Now, as somebody who's runs a private sector company delivering for the NHS, does that whole debate frustrate you? Do you think it's holding, in a way, it's holding things back? We get obsessed by the process rather than what comes out the other end. And I mean, one of your priorities, I know, is creating health value for NHS primary providers through your business model. But how does that actually work? And how can you convince people that you're not just there for the profits?
Well, my stakeholders want to do more than just profits, and they really are very important. The whole ESG agenda now, as we're seeing in the investment market. But to answer your question, yes, it is rather frustrating. And I think it's around a sort of a lack of focus on the fact that the NHS can be free at the point of delivery, but in many respects is already delivered by huge chunks of private organisations. I mean, without treading on too many toes, 95, 98% of GPs are independent contractors. Yeah. A lot of surgeons have a private practice as well as an NHS practice, but of course, has to be careful how one says that sort of thing. And historically, the private finance initiative, which we are not, we're a conventional property company, the PFI got a terrible reputation, but it did deliver the biggest programme of post-war construction of hospitals on time and on budget, which is something that people lose sight of. Anyway, we operate in a complex society, and some of the points that cropped up earlier are really very interesting. In life generally, the urgent can quite often crowd out the important. And what Patricia and Justine were saying is that about investing in this wellness agenda and the levelling up agenda will pay enormous dividends for the country through improving the lot of the citizens in these less well-off areas so that we all get better. And that inevitably will reduce in due course the incredible cost that the NHS has for us as a country. Living longer is great, but it means that there's an increasing demand on healthcare services as people get older. Anyway, from our standpoint, we are very happy to work with anybody on a cross-party basis, and our real ambition is to get more money flowing faster into these projects in primary care to accommodate the much wider range of services that are needed now. We haven't specifically talked, I don't think, very much about mental health. My goodness, the pandemic has a huge legacy on mental health. I don't think there can be a single person in the country that hasn't at times felt touched by the incredible pressures that the pandemic has put upon people. And mental health has a huge role to play in the community, and very often our medical centres are used, and a large part of it is for community mental health. But so much better to deliver that out of proper premises than out of very small and cramped premises where there isn't room for the mental health team. So there's a vast amount to do. We're here ready and very keen to play our part as a socially responsible business in levelling up the country. And my goodness me, you know, I live in London. When you go to some parts of the country, it is absolutely astonishing, the width or the variety of situations that there are out there, and improving the primary care facilities, I think, will have a fantastic role to play in that regeneration of communities, not least on the high street, as people have said. You know, we've already got some projects where we're repurposing failed department stores as medical centres, so the medical provision can be at the real heart of the community. And for those of us who drive, we forget that if you don't drive, actually local accessibility is incredibly important, and sometimes where better to be than on the high street, where the facilities would be very local rather than miles away in an out-of-town business park.
That's a really important point, isn't it, Patricia? Because, and it goes back to what we were talking about earlier about the rural-urban divide, where, I mean, and I don't know Shropshire particularly well, but where I do know well, in North Norfolk, you can be 40 miles away from a general hospital. You can be 10 or 15 miles away from your nearest GP surgery. And people who live in urban centres just can't even comprehend of that, can they? And what can be unlocked, particularly to help people in remote rural areas?
So I think there's got to be a balance of both centralisation of having good facilities in good towns. So if you take Shropshire, we've got a number of market towns. So having good facilities which are based around those market towns that people can access both through public transport and driving is really important. But then having that kind of using those centres as satellite centres, because within places like Shropshire, Norfolk and other rural areas, there has to be elements of mobile linkage, so that, you know, as I say, services like mine are people that go into folks' homes, but being able to connect that back with central services, you know, local diagnostics, near patient testing, etc., that can link back into bigger hubs, because there is no doubt that having larger primary care centres enables you to have a plethora of skills that can then respond to that quickly. So I think in rural areas, you've got to have the balance of centralisation within market towns that allow you to have that suite of facilities that are flexible and mobile enough to be able to go into some of the more remote areas and target teams in some of those more remote areas. So for example, we're doing quite a lot of work with some of our farming and agricultural communities that have felt very isolated during COVID, where we've seen some of the biggest spikes in mental health and suicides, so that again, it's how you link those services together so that you've got a central point where people can be monitored, get the support and get the access and the important word, coordinated access and quick response to services, but it's agile enough to be able to go out to those remote areas. So it isn't reliant on the individual having to make that connection, if you see what I mean.
Let's look at, before we wrap up, let's go to each of you. And if you can each maybe give me 2 or 3 things that you would like to see happen, whether they're government inspired, whether they should come from within the NHS or whatever, 2 or 3 things that you think would actually improve the levelling up agenda as it relates to health. And I don't mean renaming the Department of Health, the renaming sort of Department of Levelling Up for Health or something like that. Harry?
Well, we've been developing an ASK, which is really to ask the NHS to top slice some £300 million worth of money, which sounds like a lot, but would provide something like £4 billion worth of investment in primary care. And that could be focused and targeted on the parts of the country that have the biggest levelling up challenge, in the context of a service that costs £150 billion a year to run. £300 million on an annual basis is not a vast sum of money. And I think that would pay enormous dividends for the country, as well as bringing about a fantastic modernisation in hub primary care centres, which would deal with a lot of the integration of the services that we've talked about today.
Patricia?
So I think, just on a theme with Harry, I think that we need the move of funding not away from acute services, but the repurposing of that funding, so that we're focusing on the downstream elements. And I think there needs to be more around. We've just had a decision around national insurance and a focus on social care, which I absolutely welcome. But that is very much dealing with the crisis of today. And I think there needs to be a relook on local government, not just health service funding, particularly around children and young people, because if you crack the children and young people prevention agenda, then you start to really deal with some of these levelling up issues. So I think it's social care is a starting point, which is an immediate pressure and issue across health and social care. But I think that funding stream into not just primary care, but community and local government services with a real focus on children and young people really sets the prevention agenda, I think.
Justine, if you can give us a couple of things you'd like to see being done in this area, and then maybe wrap up our discussion, draw it all together.
Well, I'd absolutely endorse what Harry and Patricia are saying around prevention and getting upstream of those challenges. So that would be, I guess, my first area that I would really like to see a much more concrete strategy around. As I mentioned before, I absolutely think businesses have much more of a strategic role to play on healthcare and well-being than perhaps we or they had understood before COVID. And I hope that certainly partly through this work on the levelling up goals, we can also explore what that might look like with the employers we're working with. And I think the third thing is this point about young people. And so a lot of our discussion is about how we stop, sort of minor health issues becoming bad health issues and going into the acute sector. But actually, there's a piece of it which is about well-being and happy people and how you can make sure that actually you get the most out of your health and well-being. And I think there's that piece of it that for schools in particular, I think there's a real role for schools to play around this wider well-being agenda. And I think it also ties to some of the levelling up goals like good advice and experiences and this sense of how do you have a sort of happy, fulfilled life, not just how do you not get ill and badly ill. So that would be the third thing. And I think in relation to the discussion we've had, I mean, what's always interesting about any discussion on health is how on the same page people are. I don't think there's a massive divergence of views either across parties or in the wider public about probably what good looks like. I think the big debate is how do we get there faster? And I think COVID has really perhaps turbocharged that discussion. Let's hope that having seen some progress around sort of health and social care, that we almost don't lose the momentum now. Clearly, there'll be more information and proposals that come out around how we're going to use that additional investment that come in. But I think it's a key moment when perhaps we can see if we can get people on the same page around what good looks like. And in the meantime, I think what also has come out of this discussion is almost how successful healthcare is absolutely a team effort. and whether it's all the work that Patricia's doing and ICS, which is all about partnership, whether it's the role that PH Properties play and Harry's role for his business, which is fundamental, because you can have a strategy, but unless you're able to deliver it, then, you know, it's not worth anything really. I think it's this sense of the team effort being how you're actually going to find your way through to health and levelling up being something, you know, that really shifts the dial more broadly. But a fantastic discussion. And I guess it's just a chance also for me to say a massive thank you to everybody involved in the NHS in whatever guise, because, you know, it's really steered our country through this pandemic. We're not quite out of it yet. Who knows, you know, what the next few weeks and months hold. But I think it's just underlined how absolutely vital to us that work that goes on in the NHS every day is for everyone. We've all been touched by it. I certainly have over the past year. So yes, it's an amazing institution and organisation, and one that we're all absolutely invested in.
Well, a very positive note to end on. Harry Hyman for PHP, Patricia Davis, thank you very much indeed for joining us, and of course Justine too. All of the webinars that we've carried out under the Levelling Up Goals banner, you can get them on the Levelling Up Goals website if you want to catch up on our various discussions. Thank you for joining us. See you again next time. Goodbye.